So thank you for inviting me to give this talk. And so I will talk about ColoNode, analysis of colorectal cancer lymph nodes, an improved method for assessment of tumor stage and prognosis. So colorectal cancer is globally one of the most prevalent cancers and a common cause of cancer-related mortality. The number of new cases is projected to increase from 1.9 million in 2020 to 3.1 million in 2040. The curative treatment is surgery, but 1/4 of the patients will relapse. The majority of patients with relapse will die from their cancer. Patients at risk of relapse benefit from postoperative adjuvant chemotherapy that can cure patients with minimal residual disease and will increase disease-free survival time. So the selection criteria for adjuvant treatment is the diagnosis of colorectal cancer and preoperative staging, decisions about neoadjuvant treatment, surgery, primary tumor and lymph node analysis, and then the allocation to TNM stage 1, 2, 3, or 4, and decisions about postoperative treatment. And in this part, if you press further, the lymph node analysis is very important. So why is lymph nodes analysis of lymph node important? It's because the major pathway for tumor cell dissemination leading to distant metastasis and cancer death is from lymph nodes leaving from the intestine to the draining lymph nodes, and from there to distant sites in the body where they for the distant metastasis, like the livers in the lungs. Next. The single most important prognostic factor is determination of lymph node status, that is, whether tumor cells have disseminated to lymph nodes or not. And ColoNode is designed for this very purpose. Next. The ColoNode assay is made up of 5 biomarkers with prognostic value. This is CEACAM5. This is a proxy for number of tumor cells. KLK6, a proxy for aggressive tumor cells. SLC35D3, a proxy for aggressive tumor cells, also that one. POSTEM, a proxy for tumor growth promoting fibroblasts. And MUC2, a proxy for relatively harmless tumor cells. Next slide, please. All 5 biomarkers are detected as mRNAs. The 18S rRNA is used for normalization, that is for calculation of expression levels and for estimation of RNA quality and concentration. Concentrations of mRNAs and 18S rRNA in the samples are detected by real-time quantitative RT-PCR with RNA copy standards in a 2-triplex qRT-PCR assay. Next. So the first part is the detection of disseminated tumor cells in lymph nodes. Comparison between ColoNode and the standard method. So 2,393 lymph nodes were divided. 1/2 went to routine to the clinic, and a section from there was inspected for the presence of metastasis or micrometastasis in the lymph node. And the response is like, yes, metastasis is seen, or H&E positive, or no metastasis is seen. And the other half of the lymph node was homogenized, and RNA was extracted, and determined the amount of tumor cells by the amount of CEACAM5 mRNA level. And 2 levels are like numbers of CEACAM5 corresponding to metastasis, and just numbers of CEACAM5 mRNA molecules corresponding to scattered or small clusters of cells. And if you press the next step. If you press the next step. So here is the result from this, where you can see that to the right in the figure, you can see then that those which had micrometastasis and metastasis had very high levels of CEACAM5. That's on the y-axis is this level. But also notably that there's a lot of lymph nodes with high levels of CEACAM5 also in those where no micrometastasis or metastasis was seen by the pathologist. So next slide. So here is a summary of this the way you can see that actually there are quite a few, over 400 cells which had metastasis level of CEACAM5, but only 151 were detected by the pathologist. And if you press the next. So this meant that there was, can you press the next? Yes, so ColoNode increased the detection of metastasis and micrometastasis by 3.34-fold, so compared to histopathology. And also the other finding is that CEACAM5 or tumor cells disseminated to lymph nodes were found in the 73% of the lymph nodes. So next, please. So the other thing which is with the ColoNode is the allocation to risk group. So risk factors for CEACAM5 positive lymph nodes are defined by the expression of biomarkers KLK6, SLC35D3, POSTAN, and MUC2 combined in a formula. A risk factor is calculated for each lymph node which is positive for CEACAM5. And the result for this from the formula can be either of -1 and 0, together grouped as low risk, 1, which is medium risk, 2, which is high risk, or 3, which is very high risk. And so here you see an example for one patient where 29 lymph nodes were investigated with different risk factors. And the next. So the lymph node with the highest risk factor defines the risk group of the patient to which the patient is allocated. And in this case, then the highest risk factor was very high, or 3. So this is a patient of risk group 3. So the next. So we performed the ColoNode study, and the aim was to validate our previous findings in a new large clinical material. And the previous findings were ColoNode analysis identifies significantly more patients at risk for recurrence after curative surgery for colorectal cancer than standard histopathology. And the other previous finding was that ColoNode analysis allows allocation of colorectal cancer patients to groups with different risk of recurrence. Next. So the design was a prospective study. Patients received post-operative adjuvant treatment according to present guidelines based on the results from standard histopathology. ColoNode results were not known to the attending physicians. It was a multi-center study, 8 Swedish hospitals participating. ColoNode analysis was performed on all lymph nodes that were examined by standard histopathology in the clinic. And this study was performed in a double-blinded manner. Next, please. Next, please. So the ColoNode surpassed histopathology in identifying patients at risk of recurrence. There was a clinical material of 196 colon cancer patients from receiving curative surgery. 36 patients had died from their cancer or lived with recurrence disease at 3-year follow-up. All lymph nodes, an average of 21 per patient, were analyzed both by ColoNode and histopathology. The result was that ColoNode risk group 1 or higher identified all patients who had recurred that were identified by routine histopathology. This was 21 patients. And more importantly, identified additional 9 patients who had recurred, 25%, which was a highly significant difference, an increase in detection of patients. ColoNode clearly identifies risk patients, and the difference between in disease-free post-operative survival time between patients in the high group, that 1, 2, and 3 together, or the low group that is 0 and -1, was 11 months, as is illustrated in this Kaplan-Meier graph here. The hazard ratio between the low and the high group was 6.84. It was a very big difference. So they went further to a comparison. Then the different parameters used to characterize and estimate the risk for recurrence for the patients, and in this group, so the ColoNode as such was the most efficient marker. It was 6.84, as we said before, and the lymph node status by the standard histopathology came on second place. This is PTN stage there with a hazard ratio of 5.84. And then if we went further from univariate to multivariate analysis, so if you go further a little bit. Yeah. So in the multivariate analysis, the standard method, standard histopathology, totally lost its significance, and turned out that ColoNode still was significant with a hazard ratio of 4.24 in the multivariate analysis, and was independent but significant hazard ratios also for lymphovascular invasion in the primary tumor and perineural invasion. So next. So the multivariate analysis proved ColoNode risk group 1, 2, and 3 as an independently high significant risk factor. Lymph node status by standard histopathology lost its significance as a risk factor in multivariate analysis. So what about the risk groups, patients' risk group as basis for postoperative treatment? Well, here's an interesting group. The low group is 0 or -1. This group constitutes 51% of the patient, and the recurrence frequency was 4%. Very low. So these patients are potentially cured. Next. So the medium group, this is medium risk. This is a group of 20% of the patients with a recurrence frequency of 11% and the hazard ratio of 2.4. And only 3.5 months longer difference compared to the low group in survival time. And the next, the high and very high groups, on the other hand, they constituted almost 1/3 of the patients, and they had a high recurrence frequency of 37%, and the hazard ratio was 10.64. And the difference in survival time between the low group and the very high group was 20 months. So very high risk for recurrence, and adjuvant treatment and follow-up is recommended there. But probably also for medium. So next, please. So summary of clinical evidence. It's a sensitive and specific detection of lymph nodes harboring disseminated tumor cells. The signature of the 5 biomarkers allows allocation of patients to groups with different risk of recurrence. Categorizing patients by ColoNode risk group surpassed standard histopathology in identifying patients at risk of recurrence. 25% of the patients who recurred were identified by ColoNode only. No patients who recurred were identified by standard histopathology only. The ColoNode risk group is a highly significant independent risk factor. Patients in the risk group 0 or -1 have very low risk of recurrence. That is, the patients are likely cured by surgery alone. Patients in risk groups 2 and 3 are at high risk of recurrence and are likely to benefit from postoperative adjuvant treatment. So this means that ColoNode yields improve lymph node metastasis analysis. So benefits of ColoNode is it prevents 25% of undertreatment by accurate detection of lymph nodes with aggressive tumor cells, and it prevents overtreatment by accurate detection of lymph nodes with less aggressive tumor cells. Advantages gained are for the patients, cure, a longer postoperative disease-free survival time, and less suffering. For the attending physicians, secure diversified prognostic with 4 risk groups as basis for decisions of postoperative treatment and follow-up. For society, reduced cost due to lower incidence of recurrences. So this is the group, the research group behind this, and who have founded the company Hyloprobe in order to be able to take our research to the benefit of the patients to make ColoNode. And we also acknowledge the funding sources that we have had during this way. So thank you for listening.